I'm going to talk today about a bit of a journey that we've been on in New South Wales, and it has been transformational change that's taken over 8 years to do that kind of system-wide and turn the beast around that is New South Wales Health and to get things implemented at scale. So I'll just cover off what our value-based healthcare, what it means to us in New South Wales, have a look at our journey so far and look at what our future approach is. So New South Wales Health, we do tend to eat the health budget. Our budget, the whole budget of New South Wales, we'd like all the money, but our budget is about $37 billion. We are, a massive health service. We've got 8 million residents that we service. We provide 2 million inpatient episodes. We've got, probably around 200,000 staff at the moment, and that's growing. 1.4 million emergency incidents responded by New South Wales Ambulance, and you'll get these slides, so I won't go through all of them, but we are a very big health service. Unlike Victoria, we are not as devolved, so we have a tight approach in our service agreements with our local health districts, so tight in terms of what we expect from them, loose in terms of how they deliver, as long as they deliver the outcome, but tight in terms of how we measure what they do and assess that kind of performance. However, despite our massive budget, there's always that elephant in the room. It's never enough in health. Demand is continuing to grow. There's the increasing sophistication of technology, community expectations, ageing of the population, people living longer with chronic disease. You'd know it all as well. So we've had to really have a good look at how we invest and how we make that informed investment decisions in New South Wales. So, as I was touching on, there's been a lot of change in health. So at the system level, we've spent the last few years really implementing value-based healthcare. It's our BAU way of doing things now, so it's not such a thing anymore because that's how we approach everything in New South Wales. So we're not running it as a separate program anymore because it's BAU. At the government level, there's been a big, and I'll touch on that soon, focus on evidence-based investment, the increased sophistication of data and data linking so we can actually follow the patient journey and really make those evidence-based decisions, and technology advances and the growing use of virtual care. And our Director of Virtual Care will come and present at the workshop this afternoon. So how do we define value-based healthcare in New South Wales? So there's kind of 4 components. The main thing is we focus on the health outcomes that matter to patients. So that's both those kind of clinical outcomes, but also what patients want and what's important to them. And sometimes that really differs from the clinical or the perception of what clinicians think are the outcomes that matter, and I'll touch on that in a minute. The experience of receiving care, so the patient and carer experience, the clinician experience of providing care. We're the first place in the whole world at scale to implement a clinician experience survey, and I'll touch on that a bit later on, and the effectiveness and efficiency of care. And normally, we would say that effective care is usually efficient care. This is one of our clinicians who's led the implementation of renal supportive care. So Professor Peter Choi, he's a nephrologist, but he's also the Director of Medical Services at the Hunter New England Local Health District.
My name's Peter Choi. I'm a nephrologist, a kidney specialist, and the Director of Nephrology at John Hunter Hospital in Newcastle, New South Wales. So, leading Better Value Care Renal Supportive Care program is a new model of care that we have been able to offer to patients with end-stage kidney disease and severe chronic kidney disease. Renal supportive care is designed to plug a gap in the traditional care that we provided to patients with kidney disease. In essence, it's the application of the principles and the practices of palliative care medicine and symptom control to the specific context of patients with kidney disease, and specifically, most commonly, patients who are on long-term dialysis. Many of the renal disorders that we deal with affect young people, affect children, young adults, but in general, renal disease is most common in patients who have other disorders, heart disorders, liver disorders, connective tissue disease, So for that reason, most of our patients are on the more senior end of the age spectrum, but compared to a lot of other chronic diseases, we have a lot of young patients as well. The disease processes are often complex and affect many aspects of their lives, and their disease process is often difficult for other non-specialists to engage with. Patients with kidney disease often didn't live very long. The dialysis procedures are often very arduous. They often have a significant impact and are invasive upon the daily lives of patients. And they're often not that successful in terms of removing the symptoms that the patients suffer. What renal supportive care seeks to do is to deal with those symptoms that dialysis can't fix. Historically, for some patients, they were faced with a very difficult choice of either going for a dialysis treatment that they didn't really want or accepting a non-dialysis treatment that might deny them appropriate care going forwards. Renal supportive care allows all patients now to have a clear choice about what they want for their care. Renal supportive care, since its introduction, has made a massive impact upon the delivery of care in a way that I've not seen in many other situations over the last 20 years. It affects everybody that touches the service. So firstly, for patients, it's transforming in the care that they're able to receive, and it's liberating in the choices that they can make for themselves. For the services that provide renal supportive care, it's meant that we can provide a much more balanced and a much more patient-focused care. It allows clinicians in a way to work in a way that is so patient-focused that it provides greater satisfaction at work and a real sense that we're making a difference. And that is very specifically due to the availability of renal supportive care.
So that was fairly early into our journey of leading better value care, and renal supportive care was one of our cohorts. And so the big question is, did it work? So we've just finished evaluating renal supportive care, and what we found, so from a volume perspective, the uptake has been significant in terms of how many patients have elected to go down that pathway, to the point that it has helped us manage our demand for dialysis. Some of our private dialysis units actually found it hard to fill their chairs. It's had a major impact on home dialysis as well. The most patients, so importantly, the patients, the majority of them rated their experience good or very good. And we had, because some of it is end-of-life care, we had a specific kind of patient experience survey for that cohort. It wasn't our normal patient experience survey. So basically, over time, we listened to what the patients said, and their satisfaction with the service went from about 70 to 83%. Really importantly, fewer renal supportive care patients died in hospital. So that was really quite significant, so they could die at home. There's been some studies published by some of our nephrologists that when patients actually stopped and went down that conservative management pathway, they actually lived longer because they weren't having all those interventions at the end. So that was interesting, and that's been published. And that, a massive amount of patients, impact on home dialysis. The clinician feedback, and you heard some of that from Peter, was very positive. There was some concerns around, once the momentum of implementation was done, how it might continue into BAU, but it has continued. And there were some challenges, as there always were, but they were kind of quite minor compared to the service. And surprisingly, when we put this in, I remember arguing with Treasury that this was about a better patient experience. There would be no economic benefit. well, very surprisingly, that there was a significant economic benefit, and that was because of that interaction with dialysis. So just moving on, so as I touched on at the beginning, our government now is very focused on how we invest. So we've got a relatively new government, or they've been in a couple of years now, but over the last few years, our New South Wales Auditor General's had a look at how government made investment decisions, and pretty much found that across government, the evaluations weren't robust enough to inform government decision making. So that then sent Treasury on a journey around the world, and I think and they ended up in Washington, where they have an evidence bank, and they brought that back, and that's been implemented in New South Wales. And it's now mandatory that monitoring and evaluation occurs and informs investment decisions, and that includes disinvestment and reinvestment, as well as new funding. So they revised every single guideline, and that's just 3 of them up there, and I've been on all of those working groups representing New South Wales Health, so I'm glad that period of revision is over. Anything over $10 million, and we spend $10 million by morning tea in New South Wales, so that's $10 million over 4 years, so most of our initiatives easily cost $10 million, must have a process, outcome and economic evaluation, so we're very busy at the moment. And I think, I really support this because as you all know, there's many good ideas in health, but whether those good ideas actually deliver the impact for patients and clinicians, that's another thing, and it's something that we really have embraced to testing. One of the things that I observed, and it was really interesting getting the culture changes, we have these great ideas, but people can't tell me clearly what problem they're trying to fix and what's the consequence of not fixing that problem. So we've really taken a kind of step back and said, well, you need to articulate what your case for change is and what issue you're addressing. And that's a real challenge. It's actually a hard thing to do, and now all our business cases that go into our budget submissions must have a case for change, and it's a government requirement. We want to make sure we're not fixing things that are not broken. We need to involve our stakeholders so that they can understand what change is needed and why. We need to build on a lot of foundational work that's already occurring as well. So that's been a big change of focus, and we've done quite a few big, so MPPs, our new policy proposals, big cases for change. So one was around older people, so over 65s using our system. That was a massive big case for change, and there's some very significant aged care reforms coming in across the nation from the 1st of November, so that stand us in good stead. We've done one for diabetes management, and when we do these cases for change, we're not just doing them in isolation, we work with our clinicians and our patients, so we've got all of those views in that case for change, and wound analysis as well, but that's now a mandatory requirement for everything that we do. So there's been quite a few challenges changing the beast that is New South Wales Health and bringing it into this kind of new culture. One of the requirements for in Treasury is that we have independence of evaluation, so that people that are implementing the initiative or reform have to kind of be arm's length to the evaluators, and that's because you don't mark your own homework. So that's been quite a cultural change. So why do we evaluate? Well, one, it's to prove it's more than just a good idea. We need the actual evidence. We now have to report to government on all our evaluations, and they're going to be published unless there's some reason why, a commercial kind of reason, or, if it's for a very sensitive and vulnerable population. And importantly, because we're spending $37 billion of taxpayers' money, and we need to make sure that we are delivering the optimal mix of services for the taxpayer. So I think that's probably the most important reason for me, and to look at whether we're producing the best outcomes and what patients think, and then to decide and assess that impact and whether we've achieved the outcomes that we wanted. So just to show you how we start off doing this, so we always have to develop, and that's a requirement now of business cases in New South Wales, a program logic. And what a program logic is, it kind of represents how a program is intended to work by linking activities with the outputs the impacts and longer term outcomes. So down the bottom there, people used to call it the problem. Well, I think it's the opportunity that we're trying to address. And this is our virtual care program logic, by the way. And then the kind of foundational activities that will help you get that change. And then leading up to your kind of outcomes and the vision. So up the top's our vision. So in New South Wales, so, you know, there's this big culture of let's jump straight to the data and we'll start from there. Well, that's not how we do it. So we develop our program logic. We then get our evaluation questions. We then get our measures, and then the data comes last. So we are really focused on measuring what we should, not just what we can, because we've got the data. There's been quite a lot of challenges along the way because, you know, we are a very data-rich place in New South Wales, and I'll show you some of that in a minute. But there's that whole burden around evaluation and you know, chief executives having to report on everything. So we like to collect that data once and use it for many different purposes, and we're really driven to do that and fill any gaps along the way. So we have created a massive virtual registry, which is called ROVE, the Register of Outcomes, Value and Experience. So for all our leading better value care cohorts, and there's 2 cancer ones that were in there. So we had direct access colonoscopy, which is a really interesting one. It's been in the media a lot recently, and the hyperfractionation for breast cancer. So this is a massive linked data set that anybody with a New South Wales Health ID can access, and there's dashboards for all of their initiatives by LHD, by hospital. And so it's linked to a whole lot of stuff. And we've just been able to bring in the National Bowel Cancer Screening Program. So that's an external data set, and link that in. So that's really important for us for our direct access colonoscopy program. So that lets us look at that patient journey across all the different care settings for all of our cohorts. And our cohorts are growing as well. So they're quite big ones there. So putting the patient first is at the centre of ROVE. I know that sounds funny for a massive linked data system, but we've also linked in over 100,000 patient experience surveys. So we can start looking at some really interesting questions like what was the relationship between a patient's experience and their likelihood to be readmitted. So we've had 3 major studies done for heart failure, COPD, and the diabetic foot. And what it showed, we could actually predict patients who went home without a good understanding of their discharge were 30% more likely to be readmitted. And that was a clear link between how they answered those questions in the patient experience survey and then whether they got readmitted. We can look at the difference between patients' acuity, how sick they are, and what their experience was like. And we're finding some really interesting, a lot of researchers are using this now as well. So we've got, that's being built as we speak, and it's amazing. So as I said, we've also developed a clinician experience measure. So we got Macquarie University to have a look around the world to see who was measuring at scale clinician experience, and no one was really. There's a lot of do you like your job kind of surveys happening, but nothing that really measured clinician experience. So we worked with over 400 clinicians, and I'm very proud to say we did not let one bureaucrat get involved who designed this survey. And it was quite interesting when it was went to our secretary and our exec. You know, we had senior people going, I would have thought that this, and our lead from Macquarie University said, no, that didn't come up. And the clinicians really own this, and for some reason it resonates. So every time we send it out, we get more than our sample size. And I think because it's quite a short survey to start off with, and then we can contextualise it based on whatever the initiative is. So we are building up a massive data system now where we can look at clinician experience across the system. So these are the kind of areas that our clinicians identified. We've just retested it. It's been published. It's been validated. Anyone can use it now. So that's been a major piece of work because we're doing it at scale as well. Really interesting, some of the early indicators for virtual care around the patient experience and the clinician experience. So I haven't got this slide up, but when we did our virtual care assessment for both, the mental health was a big early adopter of virtual care. So the clinicians really loved virtual care if they could have the video turned on so they could see patient reactions. Patients love being anonymous with no video. So I just remember handing that over to our head of mental health saying, sort that one out. So it was really, it's really good to be able to get this information and look at the patient's perspective and the clinician's perspective, because often they differ. And this is just some of our early virtual care survey findings. So that's been really important because there's been a lot of myths around virtual care and a lot of sensitivities, particularly in rural areas, around you're going to shut down services, when in fact this is filling gaps in services. So I guess we'll learn more about this afternoon, but economics is used as both a decision-making and a monitoring and evaluation tool. Our government and particularly our exec are using it more and more to inform investments. So this is my kind of last wrap-up slide. So there have been a lot of challenges. This has been a big journey and a lot of cultural change needed to bring in that culture. Just understanding that evaluation and research are not the same. Monitoring for evaluation is not the same as performance monitoring. We don't do that, but we use some of those data sets to link into our monitoring sets for evaluation. We measure what we should and not what just what we can. Governance is really, really important. I'm rescuing so many evaluations at the moment because there's been no proper governance and that areas haven't liked the outcomes, and because we haven't had that governance or expertise over some of our evaluations, it's pretty hard to retrofit and to rescue things that have got away. Using that triangulated data, so bringing together your patient, your clinician experience data and all your administrative data sets is really important, gives you the whole picture. And just to really emphasise that culture is still developing and that independence is really important. So that's been our journey in New South Wales. That's it, I think.
Just carrying on from that, I'm wondering, Liz, it was great to see the transformation that integrated data sets and integrated evaluation, which we know is still down the pipeline for Victoria. Just stepping that back for us, what can we do even just at our own service level around evaluation and integrating evaluation just at our own service level?
So I don't think you need to boil the ocean with evaluation, and certainly some areas of New South Wales Health, you wonder how they're going to finish some of their evaluations. So we really like to make it pragmatic and usable, so really focusing on those kind of 4 areas around the patient and the clinician, really important because you're never going to get change unless you get the clinicians and patients on board. So really listening to that voice and being able to use and demonstrate back to those groups that you've listened. And I think just every time, and we'll do there's some really fun activities in the economics workshop, would you believe, but really understanding that if you invest in something here, that means you can't invest in something else if you've got limited budget. So really having those really open discussions about the consequences of an investment decision and what evidence you have to inform that decision. I think if you were going to do those 3 things, that would be a good conversation to have locally.